This is my presentation on diabetes mellitus and dyslipidemia. My name is Austin Keach, and I'll be kind of guiding us through what these diseases are and how they relate to exercise and what exercise prescription would look like. A little bit about me. Um, I'm taking this class this semester, and part of the reason why I signed up for this topic is I am a type 1 diabetic myself. And so it was fun and interesting to dive a little bit more into what the disease is. And then I'm excited to share a little bit of experience and perspective with type 1 diabetes specifically. So we'll jump into our presentation here. So the main things that we're going to be going over is we'll go over definitions, the scope, the pathophysiology and complications. We're also going to tap into the clinical aspects, treatment, effects on exercise, some of the exercise testing, and then ultimately what exercise prescription would look like. And then we'll kind of summarize everything, draw some conclusions, and then I'll have my references. So first off with diabetes mellitus. It's a metabolic disease characterized by the inability to produce sufficient insulin or use it properly, resulting in hyperglycemia or elevations in blood glucose. And then the insulin is going to be the primary thing. And just to kind of re-go over what that is, insulin is a hormone produced by beta cells of the pancreas, and it's needed by the skeletal muscles, adipose tissue, and liver to take up and use glucose. So kind of a little bit of explanation on insulin. One thing that was explained really well to me that made sense for me was insulin is a lot like movie tickets, the tickets to go and see a movie. The movie being inside the cell, and the glucose being the people who need the movie tickets. So sometimes there's not enough movie tickets that the glucose, the sugar, isn't able to make it into the cell, or sometimes there's so many tickets available, but for some reason the sugar cells just aren't able to utilize those tickets in an effective way to get into the movie. And so we'll go into a little bit more detail on this. The next definition we'll go over is dyslipidemia. So this is a combination of genetic, environmental, and pathological factors that can work together to abnormally alter blood lipid and lipoprotein concentrations. So this is all going to happen in the bloodstream and is also going to be very closely tied with diabetes, specifically type 2. So scope of diabetes. So more than 29 million people in the United States have diabetes. A quarter of them are underdiagnosed. 86 million are estimated to have prediabetes, which basically just means being at risk of type 2 diabetes. And 9.3% of the United States population has diabetes. So this is a fair chunk of our population. So this is definitely like a good disease for us to keep in mind. 1.7 million new cases of diabetes among people 20 years and older was diagnosed in 2012. And so the Center of Disease Control and Prevention has considered diabetes as an epidemic. And a lot of this has to do with just the way our world is. We're very focused on high carbohydrate, high sugar foods, and exercise is overall, I feel like starting to be seen a little bit less and less popular. And because of that, we're seeing an epidemic and increasing in diabetes diagnoses. Scope of dyslipidemia. It's estimated that 30 to 60% of patients with type 2 diabetes have this. And so it's very, very closely tied with type 2 diabetes. And so we'll dive in a little bit more on these guys. So path pathophysiology for diabetes. Most diabetes are going to be categorized into three different sections. So type 1 diabetes, which is an autoimmune disease. So basically the body's attacking the beta cells that are producing the insulin. So for these individuals, um, a lot of them are normal, healthy adults that just their body's not producing the insulin or the movie tickets, and because of that, their blood sugar is going to be high. Type 2 diabetes is going to be people that their body's producing the insulin, but there's a disconnect in the insulin being able to be used properly to manage those glucose levels. This is going to be the most popular one in our community today, or in our society. So that's going to be the main one we'll be primarily focusing on. And then the final one, which is a little bit more situational, is gestational diabetes. So that's going to take place during the third trimester for some pregnant women. And basically, it's going to have to do with their bodies not being able to produce enough insulin for mom and baby. And they are experiencing elevated blood glucose levels. So we're going to go into some of the acute complications that we've talked about, which is going to be hyperglycemia and hypoglycemia. So we'll go into a little bit of details on that. Hyperglycemia is kind of called diabetes out of control. It's describing glucose levels frequently above the patient's glycemic goals. Some of the things that some symptoms that kind of come along with this can be headache, weakness, and fatigue. And it causes the kidneys to excrete glucose and water, resulting in dehydration. When we talk about those patients' glycemic goals, off here to the side, there's a snapshot of my continuous glucose monitor, which we'll talk about later. But the gray area in the middle is kind of where my glycemic goal is. So anything up above in the yellow is going to be considered high, or higher than what our glycemic goal would be. And then anything in the red is going to be in that hypoglycemic kind of range. With hyperglycemia in the short-term future, it's not going to be, it's going to be something we definitely want to correct and fix, but it's not going to, it's not detrimental in the short term. In the long term, when we're hyperglycemic for a while, that's where diabetic ketoacidosis can come into effect a little bit more. So this is going to be most common in type 1 diabetes, but anyone can experience this. But it's poor control of diabetes, which in which effective insulin is low or absent. And so a lot of times, and we'll talk about this more later as well, but type 1 diabetics that aren't currently diagnosed with type 1 diabetes can sometimes be in a state of ketoacidosis. And so this is going to be where the body's performing ketones. And we got this nice little meme here off to the side. Oh my gosh, did they just say their child is high? There's been multiple times throughout my life where I've said that, oh, I'm high, and people have thought something pretty negative. And so a lot of type 1 diabetics or diabetics in general will mention that, and they're referring to their blood glucose. So this is Orlando Brown. So he was a former Browns and Ravens lineman. He died at age 40 in 2011 due to ketoacidosis. So at the time of his death, he was not being treated for diabetes, and was undiagnosed at his time. So I thought this was just like a little fun fact for our professor, who's a big Browns fan. And so it's something that there's a lot of diabetics that play professional sports, And then unfortunately in Orlando Brown's case, he was not diagnosed at the time of his death, which there's probably a good chance that he should have been prior. There were probably leading signs. And sometimes if you just don't know what to look for, or breeze by it really quick, they can be things that can be easily forgotten about. As we go into hypoglycemia, when blood glucose level drops below that 60 to 70, that's going to be hypoglycemia. It's going to be where you're in that little red area on that snapshot my CGM was. So this is going to result from too much insulin on board, or too little carbohydrate intake, a missed meal, or excessive or poorly planned exercise. This can occur during exercise, or it can even occur hours to days later. With this, patients should monitor their blood glucose before, during, and after exercise, and just kind of keep tabs on it. So a little bit of like a story background. This last summer, I had attempted a 50K trail race, which is about 32 miles. And there was a lot of elevation gain. And early on in the race, I was consuming a lot of snacks, nutrition things, to keep my, just like a normal person, keep myself fueled for the activity I was doing. As I got to a certain point in the race, my blood sugar was higher than I wanted it to be. And I knew that I needed to dose some insulin to bring myself down. Little did I know that I had never been in an activity for as long as I was. So by the time I had hit, and at the time that I dosed insulin, I was probably close to 3 hours into the race. And by hour 4 or 5, my blood sugar had tanked and I was very hypoglycemic. And so kind of bringing up this meme here to the side, when your blood sugar is low and someone tells you to take insulin, that's the last thing you want to do. When your blood sugar is low, you need to be supplementing sugars, very simple carbohydrates, to bring that up, because it's not a good feeling to be in. Hypoglycemic is a very fatiguing state to be in, and it ended my race for the day once I could get to my dropout station, which was 3 miles more uphill. And I had eaten all of my nutrition and was just trying to survive to get to that dropout station where I could safely drop out and make it back to somewhere that would have more aid for me, because it can be a very dangerous spot to be. So we can move into more of the chronic complications. We're going to go over macrovascular disease, microvascular disease, and peripheral neuropathy. So macrovascular disease, this is the affected areas is going to be vessels to the brain, to the heart, brain, and lower extremities. Blockage of the blood vessels in the legs result in peripheral artery disease. Intermediate coagulation, and exercise intolerance. Treatment for this is going to be very similar to those with coronary heart disease, and symptoms can improve with exercise a little bit. Then moving on to microvascular disease, causes renopathy and nephropathy, which can result in abnormal function and damage to the small vessels in the eyes and kidneys. So one thing with diabetics is at times their eyesight can definitely take a hit. At every single one of my checkup appointments, my doctor's always very concerned about, not concerned, but always making note of where eyesight is, and making sure I'm having regular eye checkups to make sure everything's looking good from an eye standpoint. And so anyone with diabetes, this would be a recommendation to continually go in for eye checkups, and make sure that you're doing everything possible to stay away from microvascular disease. Finally, peripheral neuropathy. This is something that is typically going to affect legs before the hands. Patients may initially experience sensory symptoms and loss of tendon reflex. As complications progress, feet become insensate. The lack of sensitivity puts patients at a higher risk of trauma that can go undetected. So you've probably heard people talk about diabetics and their feet. Feet typically seem to be like the first things to see some issues with, and they essentially just over time develop some neuropathy or loss of feeling in their feet, which can be a scary thing. If they step on something and cut something on the bottom of their foot, they might not feel it. And there's a whole slew of diabetics that have not known that they cut something on their feet, and then over time they end up having to amputate a toe, or at times even the whole foot. And it's not because of anything on the diabetic side, but it's mainly just because of the infection. And so another thing that my doctor does at appointments is he will do some tests on the bottom of my foot, make sure I'm still having that sensation, and that's not going away. All these kind of diseases that we talked about are going to typically go alongside with poorly managed diabetes. Those short-term effects are going to be mainly more just ups and downs that diabetics are going to experience. These last three diseases that we talked about are going to be something that typically are going to surface when diabetes managed poorly, which is most of people that we're going to be working with in an clinical environment probably are experiencing some of these complications to some degree. So next we'll jump into clinical aspects. And so we'll jump into signs and symptoms, the physical examination, and diagnostic testing. So signs and symptoms, many with type 1 diabetes have all symptoms, while type 2 diabetes may remain asymptomatic. So polydysphia, which is going to be excessive thirst, polyuria, frequent urination, unexplained weight loss, infections or cuts that are slow to heal, blurry vision or fatigue. These are all going to be some of those signs and symptoms that are important to be aware of. When I first got diagnosed, I was about 15 years old, and I was experiencing all of these minus the cuts that are slow to heal. I was going to basketball practice and super fatigued. I lost a lot of weight within a very short period of time. In the middle, or I was always drinking what I thought was normal. And then throughout the middle of the night, I was waking up multiple times to use the bathroom. And those were all kind of signs that led us to going to the hospital and figuring out what was going on. So physical examination, patient should have an annual physical exam that evaluates the potential poor indicators of complication. So these can include an elevated resting heart rate, loss in sensory reflexes, especially to the lower limbs, and then foot sores or ulcers that are healing poorly, excessive bruises, or vascular abnormalities. As a diabetic, they should be before diagnosis or after diagnosis, they should be having physical examinations very regularly. I meet with my doctor about every 6 months. And there's definitely times where some people might need to meet with their doctor on a more regular basis. So diagnostic testing. These were a little bit more interesting for me to dive into. So A1C test measures the average blood glucose over the last 3 months. So typically how this is done, when I was first diagnosed, they did a blood draw, and then we're able to calculate that. Nowadays they just do it from a simple finger prick. And the goal, as we look at this table on the side, for a normal person, about 5.7 is where you're at. If we're reaching above that at all, we're either going to be pre-diabetic or diabetic. As I meet with my doctor, kind of the industry standard, if you will, or goal for diabetes, I feel like it's about 7 for an A1C. Better than that, it's going to be really awesome. If we get if we have a too low of a number there, we're going to be spending most of our time in a hypoglycemic state, which isn't going to be great either. So it's not necessarily lower the better. We really want to be hovering right around probably that 5.7, give or take a little bit. And then fasting plasma glucose measures the blood glucose after a single point of time after fasting for 8 hours. Typically, this is taken in the morning, after you'd woken up after sleeping. And the goal for a normal person is going to be right around 99 or below. Pre-diabetics are going to be a little bit higher, and diabetics are going to be pre-diagnosis right at that 126 or so. The goal, like once you're diagnosed, like waking up around 100 is going to be pretty golden. The oral glucose test measures blood glucose after consuming a glucose drink. So this is primarily one of the things that they do for gestational diabetes, although I'm sure it's used for other diagnosis testing when it comes to diabetes. But for example, my wife is pregnant, and our last appointment, they sent her home with a glucose drink. So it's basically just a super sugary concentrated drink. And so they'll have her drink that 30 minutes before the appointment. And so by the time they bring her in for her appointment, it will have been in her system for about an hour at that point. And their goal is that she's going to be, when they test her, she's going to have a blood glucose level of 139 or probably below. If it's going to be higher than that, then they're going to look into a little bit more of diagnosing for gestational diabetes. But if it is higher than that, we're probably pre-diabetic or diabetic. And then the final test, which is going to be the easiest, most accessible way for most people to test, is just random plasma glucose tests. This is where the no fasting is needed. We just do a simple finger prick and see where that blood glucose level is. Normal, this table didn't show where a normal person would be. I would imagine most normal people are going to be kind of right less than probably about 120 if they hadn't had a meal super close by. When I was first, a typical glucose meter is only going to read up to a certain level. So when I was experiencing symptoms right before my diagnosis, a family friend suggested me coming over and testing to see where my blood glucose was at. And when we tested, the meter that we tested on didn't even register a number. It just said that I was high. And so anything over about 200 would be a pretty solid sign that we're a diabetic of some sort. And so at that point, I went to the hospital and they did a blood draw, and I think they had my blood sugar at something like 700, which is way above what we need to be in. My body was in definitely more of a ketoacidosis state. No fun. So when it comes to treatment, no, there's no cures for diabetes. My pediatric doctor, when I was meeting with him all growing up, he always told me that there would be a cure in my early adulthood. Still waiting. It's not something that I try to stay up to date with where they're at with stuff. And I mean, all the time it sounds like they're getting closer, but as of right now, nothing's there. And so in the meantime, treatment for type 1 diabetes, it's very much self-monitoring just the blood glucose. And it's an important part of day-to-day management. And situation by situation. Every day is going to be different as a diabetic, whether you're type 1 or type 2. A lot of people try to put a lot of routine in their day. There's a lot of, especially type 2 diabetics, type 1 diabetics, a little bit of everyone, that they'll eat the exact same thing for breakfast, just so that they can have a very predictable morning. And sometimes you have to be a little bit smart about what you're choosing to use or what you're choosing to eat and put in your body, because different foods are going to affect stuff differently. And then you also need to know how to dose accordingly for the food that you are eating. It's important to set treatment goals, have these upper and lower lines of where things are at. If you look at this table or this chart here off to the side, you might be looking at it and saying that looks a little bit different than the previous one. On the previous chart, my upper limit line was at 200. This one was an earlier picture in my diagnosis, and we were shooting to do anything in between 300 and about 80 or so. So treatment goals aren't something that's a hard set. It's something that you have to meet the diabetic with where they're at. And it's not realistic. Some people have things dialed in between like 80 and 120, and their dots are always in there. And so you kind of have to meet the diabetic with where they're at, because ultimately they're responsible for their treatment. And if the best that they can do is in between 300 and 100, that's kind of what we have to work with. It's not something that you can force someone into doing better, but we should definitely encourage better so that they can avoid chronic complications. So multiple medications and new technology are available. Short acting, long acting insulin are going to be two things a lot of diabetics are using. And then for type 2 diabetics, they have a whole list of other medications that are also used, that are like an oral medication. And then there's better things that are able to help us monitor our glucose, which is going to be like a continuous glucose monitor or CGM. That's what's off on this chart to the side. It gives me instant feedback on pretty much where my blood glucose level is. And then insulin pumps are going to be a big help as well. So these tables would be good tables to make sure you just read through. It's going to have different medications listed. The medications I wanted to touch on are going to be right over here. So here off to the left, these are two examples of some continuous glucose monitors and insulin pumps. Within this picture, the picture on the right hand side is what I currently use. And technology is finally advancing that they're going to get the continuous glucose monitor and the insulin pump to talk to each other and work together to help me and everyone have better glucose levels, which is a big win. But when it comes to insulin, there's rapid acting insulin, or they also call it like a short acting insulin. That's primarily going to be used for meal dosing, and corrections on bringing a high number down to a normal range. And those can be given at any point during the day. Typically the lifespan of insulin is going to be right around 4 hours. And so that's important to keep in mind as we talk about some other things. Long-acting insulin is another thing that's used. That's one that is to kind of help set a baseline insulin level. That's going to be more used by a type 2 diabetic, while short-acting insulin or rapid-acting insulin is typically going to be used more by a type 1. And And that duration of that is going to have closer to a 24-hour duration on the long-acting insulin, which is another thing to keep in mind. If someone is using more insulin and then all of a sudden they start exercising more, there's a good chance they're going to be at risk for some hypoglycemia. So it's important to understand these insulins and what their lifespans are when it comes to prescribing exercise, and understanding when your patient most recently had a meal, had an insulin dose, all that good stuff. So we're going to dive into those effects now. We're going to dive into the effects on the ability to exercise, medication effect on exercise, acute effects on exercise, and then chronic effects. So effects on exercise, during hypoglycemia, exercise would not be encouraged. That's only going to drop them into a lower blood sugar level, which puts them at risk of passing out due to lack of sugar in their body. So typically, their blood sugar needs to be brought up into a normal range before they can exercise. And then during extreme hyperglycemia, exercise wouldn't be as recommended either. It's better to have those glucose levels in normal range for exercise. Although there is times where when someone's blood sugar is a little bit on the higher side, exercise could be a healthy encouragement to help bring that glucose level back down, because exercise does kind of work as insulin as well. It helps insulin, or those movie tickets, bring sugar into the cell and utilize it. But it's important to monitor glucose levels before, during, and after successful exercise training sessions. Medications effect. Insulin is going to lower blood glucose levels like we talked about. And then the lifespans. Short-acting insulin is going to have a lifespan about 4 hours. Long-acting insulin, lifespan about 4 hours. And so it's important to understand the patient's last eaten meal or snack, and when they last dosed, because that's going to affect how their body's probably going to respond blood sugar wise during your exercise session, and allow you to make the proper modifications, possibly have them have a snack during exercise. Or sometimes there might just simply be days that it's not a good idea to exercise, depending on where their blood sugar's at. Sometimes diabetics have a lot of up and downs, and sometimes there's just days that it's best to just call it for the day, and pick up on another day when they're in a better spot. Acute effects on exercise. So during aerobic exercise, we can expect to see a decrease in blood glucose level during or after the exercise. During anaerobic exercise, sometimes we can expect possible increases in blood glucose levels during or after. And surprisingly enough, I've seen a little bit of both of these. So this little map right here is kind of where my blood glucose level was before a long run during some marathon training for me. So obviously on the left of that chart, I was higher. I was, upper in the 200s. And then as the duration of that run went on that I was on, I during that aerobic exercise, we expect to see a decrease, and we did. We saw a decrease. And even while eating some nutrition during that run, we can see that my blood sugar was lower, and I kind of finished out in a better spot than I wasn't at the beginning. But I have had activities too that I was doing more weightlifting, anaerobic exercise, or interval workouts, and seeing my blood sugar raise to be higher after the workout than I was prior, without eating nutrition as well. So again, another really important thing to just see where your patient's at blood sugar wise, and know that exercise, whether it's aerobic or anaerobic, is going to adjust that number. And so just making sure that we can see where they're at and then know what we need to do to get them so they can be successful through that workout and finish in a spot that's going to have them feeling successful at the end. Chronic effects of exercise. There's no really major effects, chronic effects on exercise. Exercise is going to improve insulin action. It's going to help that insulin to be more effective. A type 2 diabetic who's insulin resistant, it's going to help their body accept that insulin and have that insulin be effective for them. It's going to assist in fat oxidation. And honestly, it's just going to make diabetes management a lot easier for the individual. It's going to allow them to have better regulated numbers because that exercise is helping to improve that insulin action. So exercise testing and considerations, there's definitely a few of them that are important to note. Exercise is generally not necessary, or exercise testing is generally not necessary for individuals who are asymptomatic for cardiovascular disease. And the key thing I want to point out here, a lot of, especially type 1 diabetics, they're healthy people. And the only exercise considerations that, we would give for a healthy diabetic is to just properly manage where their blood sugar levels are, and prescribing exercise according to that. For those that are in more of a possibly type 2 diabetic state, that might not be a healthy individual to start out with. That's where these exercise testing and considerations are going to be more appropriate. So the ACSM does encourage those who are sedentary, even if asymptomatic for cardiovascular disease, to receive medical clearance before they begin a program. And I would put that for someone who is a type 2 diabetic and sedentary, receiving medical clearance is going to be, I think, a very important thing. And at times, working very closely with the patient's endocrinologist is going to be super important for helping them to achieve success with exercise. An electrocardiogram stress test is recommended for sedentary individuals who desire to participate with vigorous activity. Endurance, resistance, balance, and range of motion exercise training are all appropriate for most patients with diabetes. Neuropathy can, we just need to make sure patients have proper footwear, and strenuous exercise could be discouraged. With renopathy, head down activities, jumping and jarring activities are not necessarily advised. Here on this table, this is another table that would be really good to make sure you understand when it comes to exercise prescription for diabetics. These recommendations are just guidelines. Like we've kind of talked, depending on with type 1 or with diabetics, their individual situation is going to be most important, as it is with most diseases and illnesses. And so and I have a table that's a little bit more simplified than this guy that we'll talk about. So kind of jumping into those fit principles, when it comes to aerobic frequency, 3 to 7 days per week, resistance and flexibility more 2 to 3. With frequency with a diabetic, consistency is going to be big. It's going to help that person to have more predictable workouts if they can have a routine that they can follow with. Intensity is going to be light to heavy, honestly pretty normal to most individuals. Time, pretty normal to most individuals. And type, pretty normal to most individuals. Diabetics, I feel like, are very capable of doing things that most of us do. We just need to take into consideration frequency. Consistency is probably going to be key, and then just making sure we manage and monitor where they're at and helping them to be successful with their exercise routine. in summary, diabetes is an epidemic. We're dealing with more and more people being diagnosed all the time. People are being diagnosed younger in life than they ever have. And so us as exercise professionals, especially in the clinical setting, just encouraging that healthy lifestyle is going to be awesome. Living healthy lifestyles is the main way to avoid becoming pre-diabetic and eventually diabetic. Diabetes is something that requires constant ongoing dedication. And I think that's important to note. There's a lot of diabetics in this world that are very frustrated with their diagnosis, and aren't motivated. And so as an exercise professional, especially in the clinical setting, we need to be very encouraging and helpful with these people. Give them confidence that they can be successful and help them to be successful, help hold them accountable. Ultimately, patients must cope with complications and managing themselves, or they will suffer the possible consequences. And so, again, on our part, just being super supportive and helping them to achieve their goals, and setting goals and achieving them is going to be great. Finally, physical activity can improve blood glucose control, and physical activity can also help reduce the burden of this metabolic disease and help life to be more normal for them. So again, ultimate conclusion, I think with diabetes is to help be encouraging to patients with diabetes and help them know that they can achieve their goals. And don't help them not to be as frustrated with this diagnosis. So that basically concludes our presentation here on diabetes. And so I hope this was informative. I hope you were able to understand and learn a little bit more of what diabetes is, and kind of be able to differentiate what type 1 diabetes is and what type 2 diabetes is. But yeah, thank you for listening and for taking time to learn more about this disease and listen to my presentation and let me kind of talk about something I'm passionate about. Here on these next 2 slides, we'll have my references for the information and then for images that I used. But thank you for watching.